Oh, hello. Good morning. I'm Dr. Kalyan Gangopadhyay. Welcome to the world's first Metabolic Roadinar. Today, we are going to discuss a lot about diabetes and really the practical management and implications of the various trials. So now, I'm going to pick up my friend and a luminary in the field of diabetes, Dr. Eris Singh. Let's go to his residence and pick him up. We are now what we call the Geographical Center of Kolkata. A lot of people say this is the city of joy. We start from Dr. Ronald Ross. We start from Rabindranath Tagore, the first Asian to win a Nobel Laureate Prize. We then have C.V. Raman in physics, we have Mother Teresa for peace, and recently we have Dr. Amartya Sen and Dr. Abhijit Banerjee for economics. So it's a land of Nobel laureates. So this tree of Kolkata gives shade to this. So we are going to now see another tree of diabetes, and I'm going to write to the Nobel Committee to consider a prize, Nobel Prize in Diabetes for my friend here, Dr. Eris Singh. Hello Eris, how are you?
I'm good.
Good. It's a COVID handshake. How are you feeling today?
I'm good, absolutely fit and fine.
Yeah. Oh, it's funny of this. You see, this is the only city perhaps in the world which has got boats, because it is by the river, ships, it is near the port side. It has got cars, buses, train, trams, and also a hand pulling rickshaw. I think it's the only country in the world which has got so many amenities. It is just like diabetes, so many problems with diabetes. And I feel that, of the many problems, there has been too much emphasis on the heart. What do you feel? I mean, is it just the heart that we need to concentrate on for diabetes? We are here at Balwani Singh's seating house. भाई साहब चार चाय देंगे, चार चाय. This is the famous hard of Kolkata. People drink tea in these earth pots. It adds an added flavor to the tea. It's different drinking tea here in this earthenware rather than having it from a cup. It tastes completely different. This is the feel of Kolkata.
So I used to come to this place during my postdoctoral courses because it's very near to the SSKM hospital, IPGMR, Calcutta, and I used to stay in the hostel nearby. Every day, entire group of DMS students used to come to this place to have a bar of chai. So that's an amazing place here.
On a Sunday morning, there is nothing like a hot cup of tea in the har that we call in Bangla in Kolkata. Nothing like it. Absolutely. Just see the flavor. And also, you have to make a sound while you're drinking it, like this. So we were touching on the points about the prevalence of CKD. We were saying about heart disease. Somehow I feel that only recently the CKD importance seems to have come up. Otherwise, we were stuck only with the heart, and not realizing that CKD is such an important and sometimes unnoticed complication of diabetes. So, your thoughts on this? I think it is still underrated because most of the time it is not checked, and you know, if your kidney is damaged more than 75%, then you begin to have some symptoms. Otherwise, you will not have any symptoms. So it is not checked. I've seen several prescriptions of patients who has not had creatinine done for, you know, years, and nothing happens in one day. Leave aside the few cases of acute renal failure, nothing happens in one day.
Well, so yeah, I agree with you. However, I think in the entire issue came into attention after the trials. But it doesn't mean that we forgot about CKD in diabetes. Perhaps the reason might be that we had to wait long for some kind of intervention to prevent kidney disease. So perhaps I feel that the entire issue of CKD was not discussed much, perhaps because of that we could not make any successful molecule. Several molecule was tried in past 20 years since the first successful trial with ARB like IDNT and Renal trial. In between, many molecules being tried for the CKD, but we couldn't have success. In fact, much success to treat diabetic kidney disease. And perhaps with this new trials with SGLT2 inhibitor, the entire things gets rebreathing kind of a stuff, and we are discussing now CKD much more than what we used to discuss 10 years back. So I agree on that point.
Yeah, so I think it is quite like after India winning the World Cup in 1983 in the cricket, all the interest in cricket had grown tremendously, because you can see, oh, we can be winners. So I think similarly can be here, that previously we couldn't do much. Nothing showed that we could stop the relentless progress of GFR decline. So therefore, I presume the interest had dropped. And now, you had mentioned about the trials 20 years ago, and the newer trials are even better, I would say. Why? Because this is on top of all the trials before. 20 years ago, the ASARB established their place, and all these new trials are on top of maximally tolerated ASARB, still showing benefit. That has enthused us, in tackling renal failure. They are an initial promise, and I don't know how you feel. I'm going to make a controversial comment here, that a lot of people say, oh look, the Dpp4 inhibitors, almost all of them, the big ones, the Saxa, Sita, Lina, Vilda, all of them reduce the albuminuria, but it failed to prevent the progression of drop in GFR. To me, what use is a drug if it just shows reduction in the albuminuria, unless it prevents the progression of the drop in eGFR? Do you think that's relevant? If you have a drug, it reduces the albuminuria, oh, it's a good drug for the kidney. Would you agree to that view?
Well, so you can see here, this is the medicine department, and we have got the nephrology on the left side of the wing, and the part of this building has got endocrinology indoor department as well. So it's a very relevant discussion in the today's context. Now, for the Dpp4 inhibitor, yes, the comfort of Dpp4 inhibitor in CKD patient is just, acceptance of Dpp4 inhibitor in people having chronic kidney disease. But I agree with you that we don't have any evidence that suggests that Dpp4 inhibitor can prevent progression of kidney disease. It's a different issue for the clinician. At the end of the day, we want a safe drug. It may not prevent kidney disease, but at the same time, it should not do any damage to the kidney. The comfort with Dpp4 inhibitor is that because it do not cause hypoglycemia, and because the patients with chronic kidney disease are very prone to develop hypoglycemia, physician feels comfortable in using CKD, and they are absolutely right on that part. But then at the same time, the Dpp4 inhibitor is basically used to, correct glycemia, and we don't have any evidence that Dpp4 inhibitor prevents kidney disease. So I think the issue is the comfort, the minimal side effect, compliance to the patient, but true, it do not prevent kidney disease. But at the end of the day, we need to control diabetes without inducing hypoglycemia, and here lies the DPP4 inhibitor in people having CKD.
Yeah, so I think things have progressed because, you know, when I was a medical student, our teachers used to say, if there is renal failure, you must use insulin and nothing else. So that concept has, been challenged somewhat because the problem in CKD, advanced CKD is hypoglycemia. You know, patients on maintenance hemodialysis, about 40% don't need any drugs because the blood sugar is controlled. In the 60%, this hyperglycemia is usually mild, albeit a small minority do have quite high blood sugar, but majority have got mild hyperglycemia, and if you give insulin, you just beget hypoglycemia. And so the DPP4 inhibitors, it's a boon in these patients because it just prevents the hypoglycemia. At the same time, the HbA1c reduction is there without incurring the hypoglycemia. Initially, I was quite enthused by the studies where it showed that the diabetes nephropathy, the diabetes affected kidney glomerulus have got a lot of DPP4, and so therefore the DPP4 concentration in the glomerulus is increased if you have got advanced kidney disease. So theoretically, the DPP4 inhibitors were supposed to stop the progression of the CKD, but it didn't. But nevertheless, as you said, the glycemic control is important. And here is one group of drug which can get blood sugar down without causing hypoglycemia. We got number of studies of all the DPP4 inhibitors in patients with maintenance hemodialysis, showing that without incurring hypoglycemia, you can control the blood sugar. In the dialysis period, it's a big headache for me, and I'm sure for you as well. The hypoglycemia which occurs during dialysis and immediate post-dialysis period, that seems to be to a significant extent, controlled by giving the DPP4 inhibitor. So definitely it has a place in CKD, at least for the glycemic control.
So,
This is the famous Victoria Memorial. You know of this, it is exactly 100 years since it was first established, open. Queen Victoria had died and Lord Curzon had ordered a memorial for her. So exactly in 1921, so we are 100 years into this Victoria Memorial. This is a very iconic place, and this, although it is in the center of Kolkata, you can see a lot of green space around. We were discussing about, we talked about the importance of kidney disease in diabetes and diagnosing it. We talked about the failure of any medications to stop the relentless march, and that prompted further research. A lot of molecules which had come up in between, tried, failed. Now we have the SGLT2 inhibitors, which, did you expect it right at the beginning when SGLT2 inhibitors first came into the market? Did you expect, tell me hand on heart, did you expect that they will have a renal benefit?
not really. Of course, we did not expect SGLT2 inhibitor to protect kidney and heart.
Heart also, yes.
Of course, this drug had a potential theoretically on paper, considering that it is working through kidney. So, we had apprehension in, other part as well, because if you remember, initially FDA put an alert of acute kidney injury with SGLT2 inhibitor, and because there was an initial rise in creatinine with a falling EGFR, so initially there was a huge concern, in fact, with the SGLT2 inhibitor, and still, many physicians feel and a little bit anxious about falling EGFR or rise in creatinine with SGLT2 inhibitor. However, the entire game had changed, and nobody could expect that a drug which is for the treatment of diabetes can protect kidney disease. But then, it's a huge bonus for people with diabetes and kidney disease that now we have got something to offer to protect kidney disease. We had to wait for
20 years, as we discussed after the ARB's trial. So it's a good, so far for the SGLT2 inhibitor.
So I think, I was one of those who was very apprehensive, to be honest, that a drug which is churning out glucose to the urine, how can it protect the kidney? If at all, it will be bad for the kidney. So I think, like me, a lot of people were also concerned about this. So, and now I've turned full circle 360 degree, and I'm an an advocate of giving this drug now. So it emphasizes the importance, because if you feel that this drug is not going to work, it is going to cause damage, and now you feel no, it is really going to work. That's a big change in our approach. So that brings us to the two trials which had come up. The Credence trial and the DAPA CKD trial. I don't know the answer myself. Why did they choose to have CKD with albuminuria as the inclusion criteria? Is it because they did not think that it will benefit, and they thought that if I just reduce the albuminuria, I can say, okay, look, this drug reduces albuminuria, therefore it is protective to the kidney, quite like Dpp4. Is that why they chose the albuminuria as an inclusion criteria?
Not really. I think the purpose of choosing the different, grade of albuminuria was to know whether SGLT2 inhibitor works on different stage of diabetic kidney disease. So you might have patients with CKD defined as EGFR less than 60 ml per minute, and you might have a patient without CKD but having macroalbuminuria. This suggests that you are in a different stage of kidney disease. So the entire intention of both Credence and DAPA CKD was to take a different grade of diabetic nephropathy, someone having macroalbuminuria but not having CKD, someone having CKD, as you know that once the kidney disease progresses, the albuminuria reduces. So if you might get patients with CKD whose EGFR is 40 but he doesn't have macroalbuminuria, and that was the primary reason why they choose a different grade of albuminuria.
Drops, and I'm talking about, I think it's the Credence trial. The GFR drops, the placebo arm, the GFR does not drop, but then the GFR steadies, placebo arm GFR begins to come down. So this is around 8 months to 12 months, roughly 8 months to 12 months the graphs intersect. That means, it might be, you can say that after 8 to 12 months, it will stop the further progression of the GFR. Although it will start from the beginning, but the lines will cross at 8 to 12 months, then the placebo begins to drop, that the GFR goes down, and here the GFR steady. So 8 to 12 months, and that is why you cannot see the difference straight away. So this is the Prinsep Ghat. This is 180 years old now. It was way back in 1840s when it was first inaugurated. This is just by the side of Hooghly, a major distributary of.
And this is second Hooghly bridge. We call it Vidyasagar Setu.
Correct. So this on our right up is the second Hooghly bridge. This is a lifeline for carrying vehicles, people from Calcutta on this side to Howrah on that side. So you can say this bridge joins India to Kolkata.
Right, and the beauty that this bridge also hinges on two pillar. So it's basically a kind of a hanging bridge.
So this is parallel to the Hooghly bridge, which is on that side. So Prinsep Ghat, initially it was for just the European and the British people to embark and disembark from the Hooghly. But of course now it's open to everybody. So it's in a ghat concerning water, we are discussing about SGLT2 inhibitors. So one thing which always comes up in various CMEs, a question is, I will tell my thoughts and I would like your thought as well, that there is a slight drop in the GFR. So, should we be checking the creatinine for each and every person in which we start SGLT2 inhibitor? Is it mandated that we should check? My viewpoint is the drop is about 3 to 4 milliliters of GFR, which is very small, and there is no mandate, there is no recommendation, there is no guideline that you have to check the creatinine level. So, I myself do not check creatinine routinely after introducing SGLT2. Yes, for ACRB I may do, because there are the odd patients in which the creatinines go up with ACRB. That is a mandate that you have to check up within 1 to 2 weeks time. But for SGLT2 inhibitors, there is absolutely no need to check creatinine after 1 week. There were initial concerns about acute renal failure with the SGLT2 inhibitors, but I think all the trials, or most of the trials, have shown clear data that not only the acute renal shutdown is not increased, it is actually reduced in the trials. So, what do you think? Do you routinely check creatinine for when you start SGLT2 inhibitors?
No, not really. So, once you have got a baseline creatinine and you have measured EGFR, because creatinine is not enough and you need to measure EGFR, the entire SGLT2 trials are based on EGFR, not creatinine, number one. Number two, it is not mandated to check creatinine on regular point of time. This is expected that SGLT2 inhibitor will reduce EGFR, and this is how it protects kidney. Remember the RAS blocker, when it came and we learned that it protects kidney, they had also similar mechanism of reducing EGFR. Now the point is, they often asked in meetings that if someone is on SGLT, you have started SGLT2 inhibitor in someone who has got EGFR of 45, and while you are treating the patient over 2 years, 3 years down the line, his EGFR comes down to, let's say, 29. Now, should we stop SGLT2 inhibitor in this particular case? That's the question often asked. So, to me, I will ask your opinion as well. So, I would recommend not to stop the SGLT2 inhibitor. What we learned through the renal outcome trials, it was continued until EGFR was 15. So, once the EGFR drops down to less than 15, you need to stop it. But if someone on an EGFR of 45 and now EGFR has come down to 29, we need to remember that diabetes is an ongoing disease and it is inevitable that every patient will have some decrement in EGFR per year as the diabetes progresses. So, this is not a time where one should stop SGLT2 inhibitor even if the EGFR has come down from 45 to 29, because the benefit of SGLT2 inhibitor was surprisingly seen in more who has got a lower EGFR. So, my recommendation would be not to stop SGLT2 inhibitor until it touches the EGFR of 50. What do you do in your clinical practice?
Yeah, so I think the mandate, the recommendations, FDA, DCGI, it is now pretty clear that, so one bit you have talked about continuing. I will start with initiating. So, when should you not initiate or initiate? So, for diabetes per se, it is 45 for all three. If it is for heart failure or DKD, CKD, it is 30. That is the current guideline for initiation, mind you.
And just to add here, for the heart failure, now it has went down to 20.
20.
Now.
So they have got 3 classification. I think this has not been updated yet in the DCGI thing. It still stays at about 30.
Right, because very recently US FDA has given and EMA has also given clearance to empagliflozin for people with heart failure with reduced ejection fraction, and there this cutoff of EGFR 20 has been given. So, someone who has got a heart failure, diabetic disease or even non-diabetic kidney disease up to EGFR 20, you can use SGLT2 inhibitor like empagliflozin.
So the question is to initiating and continuation.
Yes.
Initiating at this current point of time, 45 for all diabetic, but if heart failure DKD is 30, but if you have started it and the patient is on an SGLT2 and it drops below 30, I see little justification in stopping it. Why stop it? Because what is our risk? If we lower GFR, it will not add on to the adverse effects. Yes, the glycemic efficacy will reduce, but surprisingly, and this is a surprise to me, that the other benefits, the CKD progression benefit, the heart failure benefit, the CVOT benefit is maintained even if the GFR is low. And the low GFR patients are more prone to develop severe outcome data. So probably we may continue it.
Right.
Even if this, but not initiate. If we are talking about a purist about initiating,
Right.
you remember if somebody's GFR is 31, you initiate, it will drop to 29.
Of course.
So that does mean you will stop and again start after 31? No. So more than 30, you've started it, fine. If it drops, don't worry. Just continue.
Absolutely.
Continue that.
You can then monitor the creatinine, as you said, frequently. It's not a mandate, but it's kind of pharmacovigilance you are doing to just check how the creatinine is moving, how the potassium is moving, because all those patients are prone to develop, this electrolytemia, and we will discuss about the electrolytes in
Yeah,
quite
I mean,
a few.
you just said about the potassium bit.
Right.
That's an important point because I remember, if I remember correctly, it was the first initial data was with canagliflozin. There were some reports of a few hyperkalemic episodes, and that scared a lot of people that this drug may be causing hyperkalemia. And I've recently gone through this data in a bit more detail, and there is a credence sub-analysis which they have done, which showed that the hyperkalemia incidence is reduced.
Absolutely.
And this is also there in the EMPA-REG.
Right.
And in the DAPA, the DAPA CVOT declared to me, not only is the hyperkalemia incidence reduced, it is also reduced in those on mineralocorticoids.
Correct, correct.
So
Absolutely.
therefore, this is completely wrong notion that it causes hyperkalemia. In fact, it may protect
Absolutely.
the hyperkalemia.
So this is a very recent data, as you talked. The credence data has come out very recently, and in fact they suggested that even someone who had a hyperkalemia was, now better, and their potassium levels are coming down. So the initial concern of hyperkalemia with SGLT2 inhibitor, in particular canagliflozin, is now completely out from the scene. The credence trial suggested that someone having a high potassium, their potassium is getting better on canagliflozin. Now, you asked about the story of acute renal failure. If remember, initially FDA put a caution that SGLT2 inhibitor can cause increase in acute renal failure.
Unfortunately, they have removed it now.
Yes, now they have recently removed because in the DECLARE-TIMI trial, one of the pre-specified endpoint was the acute renal failure, and surprisingly, there was a significant reduction in acute renal failure with dapagliflozin in the DECLARE-TIMI trial. So as I said, I mean, SGLT2 inhibitor will always surprise you. We think something else, the result comes quite opposite, and the good thing is it is beneficial for every diabetic patient, be it a CKD, be it a heart failure, be it a heart failure with reduced ejection fraction, be it a heart failure with preserved ejection fraction, be it a potassium, everywhere SGLT2 is benefiting.
And the added bonus was with the ARNI also, the hyperkalemia was reduced. So which was a little bit surprise to me as compared to, of course, that is not, you cannot use ARNI with ACRB, but ARNI on its own, as compared to ACRB, the hyperkalemia was less, which is an added benefit. But of course, ARNI, we are not using it for protecting the kidney, we are using it for mainly the heart failure. So we are here by the side of Hooghly. It's a distributary of the Holy Ganges. Such a wide river, see, so long, so wide, very deep as well. And the story goes that a young prince, many years ago, this is the story, he, in order to save his 60,000 maternal uncles, he released water from the Bhagirath. So that is why it is also called Bhagirath river. So this is the famous Hooghly river. Here a lot of Hindi movies have been shot. A movie which was the song was, what is the song? Rajesh Khanna famous song was there. Amar Prem, I think Chingari Koi Bhar Ke.
Chingari Koi Bhar Ke.
So they had gone on a boat on here, small vessel. Now while we are talking about water, it is relevant that we talk about the other concerns with the SGLT2 inhibitor, which is the urinary tract infections and genital tract infections. So, what are your thoughts? I mean, are you scared about the UTI? Do you think that SGLT2 inhibitors increases UTI? We'll talk UTI separate and GTI separate. So, UTI first, does it increase UTI, do you think? Or does it increase serious UTI, meaning pyelonephritis and all that sort of stuff? In your experience, not just experience, data, what does data suggest and what does your experience suggest? And I will tell mine.
Well, so genital tract infections are quite common, and in fact it is much more common than what we saw in the randomized control kind of trial. That's a controlled environment. In real world, somehow the genital infections are quite frequent. However, I do not agree that SGLT2 inhibitor has got much higher potential to cause urinary tract infection. In fact, if you see the head-to-head trial, the urinary tract infection was equal as of the other anti-diabetic drugs. We have got head-to-head trial with sulfonylurea versus SGLT2, DPP4 versus SGLT2, and there was no evidence to suggest that SGLT2 inhibitor increases urinary tract infection. But as I said, of course, genital tract infections are there. Thankfully, these infections are subtle in nature and managed with a regular course of antifungal drug. But then, having said that, I think it is mandatory basically to educate your patient about genital hygiene because genital tract infections are pretty common. As I said, I agree genital tract infections are higher, but UTI is similar as of any other anti-diabetic drug. The most important point is even these, so whenever we are using a drug, everything hinges on risk versus benefit. So if the benefit is too good than the risk, then I would consider that even if someone develops 1 episodes of genital tract infection, don't deny them the advantage of SGLT2 inhibitor given the data that it protects your heart and kidney. SGLT2 inhibitor are of course have shown enough evidence. There is nothing to be panic about these trivial genital tract infections.
Yeah, I think I have never heard of a single case of a genital tract infection becoming invasive and causing fungal septicemia. It has never happened in my experience, and also the genital tract infections are always or most often mild in nature, and I agree it is slightly higher than what the trial suggests. I would say about 10 to 15%. It is mild, it goes away with the usual antifungal cream, and what I tell the patients is, okay, you hold it for a week, you restart it again after you give the antifungal cream, and usually it is non-recurrent. If it is recurrent, then we have to do something about it, and many patients are prone to have genital fungal infections. Remember, many patients also have a history of balanitis. If you look at the causes of circumcision, why people get circumcision done, one of the causes is balanitis, and that is also a common thing. As far as UTI, I think this is an important area. So, as you said, the incidence of UTI is not as high as we thought it would be with the SGLT2 inhibitor, the way it works. Now, there was one data I remember clearly. So, with dapagliflozin, various doses 5 and 10 and placebo, what it showed is that if there is a person with history of recurrent UTI, then even if you give placebo, there is a 17% chance of having UTI again, and if you give an SGLT2 inhibitor, there is a 20% chance of having UTI again. Now, if you leave aside the placebo, you will say, oh my God, 20% chance of having UTI. Why? You have chosen a person who is having history of recurrent UTI. Even if you give a placebo, it will be 17%. So, here you are making it 20%. If there is no history of recurrent UTI, then it is almost touching the placebo, just marginally more, I would say 1% more or 2% more than the placebo arm. So, my practice, I do ask the patients if you have got a history of recurrent UTI and what is the definition. I think in the trials they have used that if you have 3 or more UTI in the last 1 year, that is the definition of person having history of recurrent UTI. So, I do ask that, and if there is a yes, it is, then I use the advantage and disadvantage ratio. If the patient really needs the SGLT2 inhibitor, then I would give it with a caution. If I think I can do away with another drug in a patient with history of recurrent UTI, then and only then I might use an alternative medicine.
Yeah, so As you said, I mean, these genital tract infections are not severe in nature. Initially, several case report came into causing Fournier's gangrene, and then
Yeah,
in the trial, we started looking whether the drug, has got any potential to cause Fournier's gangrene.
DAPA had shown.
In the declared TIMI trial,
Yes.
We looked for Fournier gangrene, and unfortunately, it was significantly lesser in the DAPA arm compared to the placebo.
This actually came out within a few months of the Fournier being pushed up.
Absolutely. So these are, as I said, I mean, SGLT2 always surprise you. You think that it will work in direction A, but it goes in direction B. And the good thing is all those direction B are beneficial to our patient. So at the end of the day, even one episodes of genital tract infection do not debar SGLT2 to be used in clinical practice. So I would recommend all my colleagues treating diabetic patient should not be worried about episodes of genital tract infection. Always give the advantage of the drug, a drug which can protect heart and kidney is always welcomed. So don't fear about these smaller episodes, 1-2 bots of genital tract infection, and don't disallow using SGLT2 inhibitor, which at the end of the day is going to prolong the life of human being by protecting heart and kidney.
So the only precaution I think is person having ongoing active UTI,
Absolutely.
or history of recurrent UTI, or clearly a malformed urinary tract making them prone to recurrent UTI, you of course prevent usage there unless the benefits are so much that you have to give it. So I think this summarizes the UTI and the GTI effect. So today is quite a hot and humid day. Sun bearing down on us. It becomes very difficult with this temperature and heat. Now, this brings to another question actually about SGLT2 inhibitor in tropical countries, because there were a lot of queries that if you give SGLT2 inhibitors, will it not worsen the orthostatic effects in hot and humid countries like us? I remember canagliflozin actually had data where they teased out hot countries like Mexico. It can be hotter than India sometimes, Mexico and other hot countries, and they showed that there was not much of a difference in the orthostatic hypotension or dehydration symptoms with the SGLT2 inhibitors, and I think that holds true for India as well. The simple advice I give is you drink 1 glass of extra water per day, because that is exactly the amount of urine you are going to pass extra. What are your thoughts? Should we avoid in hot and humid climates?
So see, even we had rains for quite few days, and just see the moisture, we are sweating a lot, and natural this makes concern for someone on SGLT2 inhibitor, because of course by behaving like a diuretics, it reduces the total plasma volume. And therefore, as you said, that we recommend that you take an additional glass of water, and that will do your job. So this concern is genuine in fact, and I think it should be basically a routine clinical practice that everyone being put on SGLT2 inhibitor should be advised to have extra drinking water. The better that at least 500 ml per day would do a better job than than a glass of water, and this will reduce the chance of postural hypotension, especially in those who are elderly or those receiving let's say diuretics kind of stuff.
The iconic Howrah Bridge, you can see in the distance. This is close to 80 years or more old. This is one of the, I think it's the 6th longest cantilever bridge in the world, and it is easily the busiest cantilever bridge in the world. About 100,000 vehicles every day use this. There are another 4 bridges on this Hooghly, and before those other bridges were there, this used to be the only one. So you can imagine how busy it must have been. The first vehicle to cross it was a tram. That's the iconic bridge. Now talking about legs, we'll come to the discussion we were having about SGLT2 inhibitor, and there were some concerns about peripheral arterial disease. As you know, one issue was raised in the Canvas program, Canvas trial, that there was statistically significant incidence in small toe amputations that prompted some warnings as well. However, this was not borne out in both the EMPA or the DAPA, although there were some indications of noise in the opposite direction. Should we avoid SGLT2 inhibitors in patients with peripheral arterial disease? That is the moot question. Your thoughts, and then I will also chip in. Is it an exclusion criteria for using it? For using SGLT2 inhibitors, if somebody has had an amputation, or if somebody has got peripheral arterial disease?
Well, yeah, so that's one area where perhaps we are still are little concerned. This signal came in Canvas program, as you said, but then it didn't came out in the Credence trial. The Credence also looked for amputation as a pre-specified endpoint, as of as a special adverse event, and it was not statistically significant. Having said that, the noise was still there even in the Credence. If I remember correctly, HR was 1.11, although it wasn't statistically significant. So, in one hand, to some extent, it strikes out those concerns, but entirely this issue is not yet settled, and therefore, in my opinion, if someone has got a established peripheral arterial disease or severe neuropathy, and they are high risk for diabetic foot ulcer, perhaps I would not be keen to use a SGLT2 inhibitor in these subset of patients. Having said that, the initial black box warning of amputation, which was given to canagliflozin exclusively, has been little bit taken off, and now this amputation issue is no more a black box warning, but then this is a special area where we need to have little bit of concern. So in conclusion, I would rather hesitate to use a SGLT2 inhibitor in those having advanced peripheral arterial disease, advanced neuropathy, or high risk of foot ulcer. Let's not use a SGLT2 inhibitor. Or if these patients have got known heart failure or known CKD, and you wish to use a SGLT2 inhibitor, be pharmacovigilant, look for the foot ulcers on a frequent interval. That should be my simple message.
Yeah, because these patients with peripheral artery disease are at more risk of having CV problems. So,
True.
if they have existing atherosclerotic cardiovascular disease, heart failure, CKD, proteinuria, there is a higher chance of them having it, then we should perhaps not deny them. But again, be pharmacovigilant. And I think if I remember correctly, from the DAPA trial itself, they had taken out the population of patients who had peripheral arterial disease to see the impact of the CVOT. And I think although the numbers were small, and they found that the noise was in the right direction as far as the CVOT is concerned, but it crossed the midline. So, there was no statistical significance. It crossed the midline because the confidence interval was wide, because the numbers were small, but at least it was on the side of benefit, but not statistically significant. So, I think these group we have to be vigilant. We cannot outright say, you have got a foot ulcer, I will never give you. No, if there is overbearing evidence of heart failure, CV problems, CKD, that will kill them first rather than this. So, then we should use. And luckily, in the Western world, they have more of this problem, and I don't know why. I cannot back it up with scientific data, because I remember working in UK. There's a very full house of the foot clinic was full of Caucasians, and the heart clinic was full of Asians. So we seem to have more of the heart related issues than the foot issues. So that seems to be less. Some people say oh, because many people from the villages you might be missing foot related problems. I don't think that is true. I think in general, if that was true, why in the UK you would find foot patients more of Caucasians, heart patients more of Asians. So I think there is some difference in the atherosclerotic makeup which predisposes patients to this. But that teaches us, even if you are not giving SGLT2, you should still have a look at the feet. So that should prompt us to even be more vigilant in looking at the foot.
Yeah, true. So luckily, Indian Asians have got less, prevalence of peripheral vascular disease. We exactly don't know the reason.
And CKD also.
Yes. So in one hand, the people from Asian, uh, continent have got more cardiovascular disease, but surprisingly, we have got very much less prevalence of peripheral vascular disease.
Overall, if we are looking at SGLT2 inhibitors and kidney, we cannot look it in isolation with the kidney. Kidney patients with kidney problems have higher propensity to develop cardiovascular problems, so it will tackle that. It will prevent the progression of the GFR decline, prevent the progression of albuminuria. That comes at very little or low risk of adverse effects. It has got lower risk of having acute renal failure, lower risk of having hyperkalemia, and also, by the by, also lowers blood sugar. So overall, I think SGLT2 inhibitor group as a class is, you can say it's a wonder molecule as far as the kidney disease progression is concerned. Of course, a few caveats, a few judicial points to make, that we should be careful. Patients with history of recurrent UTI, with very high blood sugar, with osmotic symptoms, with amputation or very severe peripheral arterial disease, we may have to be judicious about using the SGLT2 inhibitors. So your final take of this?
Yeah, so I fully agree with you. It's a wonderful drug. Don't be critical while using. At the same time, don't be, all go for the SGLT2 inhibitor. Of course, you will assess your patient. Try to understand whether, the benefit outweighs the risk. And with the given data, with the available evidence, this molecule has done wonder. Started with anti-diabetes drug, then shown heart benefit, becomes a cardiologist drug, then showing kidney benefit, becoming a nephrologist drug. And now we say that, SGLT2 inhibitor is a cardiovascular drug having properties to lower blood sugar. So the, entire landscape of treating type 2 diabetes today it has changed. We are 360-degree from glucose control to heart protection to kidney disease. I think the cherry at the top for SGLT2 came from the data of heart failure with preserved ejection fraction trial. We had no drug in the past that could give relief to those patients with preserved ejection fraction. Now this is one drug which has shown a positive outcome in people with heart failure with preserved ejection fraction. So you go to any sphere of life, SGLT2 seems to have given one of the best outcome. I would recommend everyone that if you are treating type 2 diabetes in your OPD every day, assess your patient. If there is no contraindication to use SGLT2 inhibitor, if your patient can afford SGLT2 inhibitor, and there are some compelling indication that if your patient has got established heart disease, kidney disease and heart failure, of course you give the advantage of SGLT2 inhibitor in all your diabetic patients unless it is confirmed.
Hello friends, I am Dr. Rajiv Kovil from Mumbai. Today two close friends of mine, Dr. A.K. Singh and Dr. Kalyan Gangopadhyay from Kolkata, took you around Kolkata and they discussed a lot of hard science. And I am here to summarize what they spoke about. Now, in the last 2 decades, chronic kidney disease has been a huge comorbidity in people with type 2 diabetes as well as people without diabetes. And it has emerged as one of the most important killers. One can estimate that close to almost 10 million deaths across the globe occurs because of chronic kidney disease. And this is something that we need to really take care of. Now, the SGLT2 inhibitors have come in almost after 2 decades. The ACE and ARBs came 2 decades back, and they told us they could prevent the progression of chronic kidney disease by causing an inhibition of the renin-angiotensin system. And 2 decades later, we have drugs like dapagliflozin, which has been shown in DECLARE study where it has been shown that it can prevent chronic kidney disease, and DAPA HF study where it has been shown that you can treat heart failure with reduced ejection fraction, and DAPA CKD where you can also prevent progression of chronic kidney disease as well as also treat chronic kidney disease. Now, this has been a very remarkable change, and as you can see, I am in a wonderful environment and I am going to talk science. Now, what is DAPA CKD all about? DAPA CKD is a trial which is done in patients who are in stage 3B chronic kidney disease. Their mean eGFR is 43, and we have included patients from an eGFR of 25 to 75. You must be aware that below an eGFR of 30, SGLT2s are not recommended. But you have approximately around 14% patients below an eGFR of 30, another 10 to 12% patient above an eGFR of 60. Majority, 75% of patients in the DAPA CKD are in stage 3 chronic kidney disease. These are the patients that we actually see in real life practice, and these are the patients whom we want to prevent progression of chronic kidney disease and also reduce what is the hardest endpoint in any clinical trial, which is all-cause mortality. And what was done, that dapagliflozin was added to standard of care. Again, DAPA CKD was done in 21 countries, almost 400 sites, and over a longitudinal period of time to see the effect of an SGLT2 like dapagliflozin on patients who are very high risk to progression of chronic kidney disease. Majority of patients in the DAPA CKD were on standard of care to prevent progression of chronic kidney disease, which is ACE and ARB. 97% of patients in the DAPA CKD were on ACE and ARBs. What was the primary outcome in DAPA CKD? It was a sustained 50% reduction in eGFR, end-stage kidney disease, renal or cardiovascular death. If you compare it to the CREDENCE study, the difference was here we use a 50% reduction in eGFR as compared to CREDENCE where they use doubling of serum creatinine. And what did we see? We saw a 39% relative risk reduction in the primary endpoint of a 50% reduction in eGFR, renal, cardiovascular death and end-stage kidney disease. Again, if you look at DAPA CKD, what is very remarkable is that all the components of the primary outcome move in the same direction. So it's not driven by one outcome, it's driven by all the 4 outcomes, and you need to realize all these 4 outcomes are hard endpoints. We are not looking at softer endpoints like micro to macro or macro to micro albuminuria. We are looking at 50% reduction in eGFR, we are looking at renal or cardiovascular death, and we are looking at end-stage kidney disease. Again, treatment was seen across pre-specified age groups. The age didn't matter, whether the presence of diabetes or people without diabetes didn't matter, whether your ACR was less than 1000 or more than 1000 didn't matter. And DAPA CKD had almost 1/3 of patients who are not the people with diabetes, and these are patients who do not have any other thing other than ACE and ARB today, and dapagliflozin offers an approach to these patients to prevent progression of their chronic kidney disease. In terms of secondary outcome, if we just remove the cardiovascular death from there and we look at only secondary outcomes, you have a 44% reduction in secondary outcomes. And what was the secondary outcome? Again, the secondary outcome was a 50% reduction in eGFR, end-stage kidney disease or renal death. So if you look at the renal specific outcomes of dapagliflozin in DAPA CKD, very strong, robust evidence there. exploratory composite endpoint of very hard evidence of kidney transplant, chronic dialysis or renal death, you have a 34% reduction in this kind of a very hard endpoint. Harder endpoints of cardiovascular death or hospitalization due to heart failure, you will get almost 29% reduction in relative risk reduction in dapagliflozin as compared to placebo and standard of care. Differentiation between DAPA CKD and the CREDENCE study was this particular data, that CREDENCE did not show all-cause mortality and DAPA showed a 29% reduction in all-cause mortality in the dapagliflozin study, and this sets it apart from the other chronic kidney outcome study where there is a reduction in the hardest endpoint, which is all-cause mortality. SGLT2 inhibitors have their own share of tragedies, misfortunes and so many hurdles. And what did the DECLARE and DAPA-HF and DAPA-CKD assure us? That there is no life-threatening side effects, whether it's related to amputations, whether it is related to euglycemic ketosis, whether it is related to urosepsis, bladder cancer, everything did not, there was no signal towards any adverse drug reaction other than genital tract infections, which we are well aware of. If I could summarize, that DAPA CKD is one particular study which shows a 39% reduction in its primary outcome, 44% reduction in its kidney outcome, and most importantly a 29% reduction in all-cause mortality. So it's a win-win study, and I think all chronic kidney disease, stage 3 chronic kidney disease, whether they have diabetes or no diabetes, they should be treated with dapagliflozin, not only to prevent progression but to treat them towards any kind of beneficial effect of chronic kidney disease.